In the United States, for now, certain drugs are directly used by physical therapists via transdermal route to relieve certain topical symptoms. The drugs are prescribed by a licensed medical practitioner like a physician or a nurse practitioner, and the physical therapist uses modality-based techniques to deliver the drug to the patient. In this presentation, we are going to look at these modalities, the conditions where drugs are used by the PT, the drugs themselves, their relative benefits, side effects, precautions, and contraindications. Let's get started. Pause the presentation at this slide and view the broad objectives. By the end of this presentation, you should be able to feel confident on these objectives. Let's begin with iontophoresis. Iontophoresis is a clinical technique in which an electrical current is used to deliver a drug transdermally, which means in simple words, delivering it through the skin. There are some prerequisites that must be considered for this to occur successfully. The skin should be permeable to the drug and the drug should exist in an ionized state. Iontophoresis is relatively safe and non-invasive. By bypassing the gastrointestinal tract, it avoids the first pass effect. To understand first pass effect, I direct you to the foundational lectures of fundamentals in pharmacology. In iontophoresis, drugs can be applied directly to the local site of a specific tissue, and the delivery can sustain over time using now available portable methods. Iontophoresis is based on principles of ion transfer. As stated before, a drug must exist in an ionized state, which means that they need to be able to dissociate in a solution into positive and negative molecules. The active ion is identified, and as such, a host of drugs used in this process is already predetermined to their active ion. When placed strategically under the electrode with like charge as the molecule, based on principles of like charges repel, the active ion is driven into the body when a potential difference is applied to the electrodes. There are also other claimed effects of iontophoresis, which supposedly facilitate ion entry into the cell. The first effect is called electroporation. Electroporation or electropermeabilization is a microbiology technique in which an electrical field is applied to a cell in order to increase the permeability of the cell membrane, allowing chemicals, drugs, or DNA to be introduced into the cell. In this case, we postulate that opening of the pores facilitate entry of ions into the cell, thereby producing a desirable treatment effect. The other effect is that of electroosmosis. Electroosmotic flow is the motion of liquid induced by an applied potential across a potential uh, porous material, such as the skin, which is selectively permeable. It is therefore also supportive of the phenomena of iontophoresis. An ionic drug is driven through the skin using a direct current with the stated amplitude and duration. You will recall from grade school physics that direct currents or DC flow unidirectionally as compared to alternating currents and is delivered via a clinical electrical stimulation or a E-stim unit. For details on neuromuscular E-stim, I direct you to your modalities class. Suggested strength of the DC current is going to be discussed in the next few slides. Options on current dosage is suggested here. You will recall dosage equals amplitude in milliamperes times duration in minutes. Thus, to deliver a dosage of 80 milliampere minute, you will set amplitude to 4 milliamperes and application time to 20 minutes. Typical current dosages are set between 40 milliampere minute to 80 milliampere minute. On this slide, you can see a number of articles published on the topic of the best current dosage. You will notice that all these studies claimed quote unquote success or successful. Bertolucci in 1982 published optimal current dosage of 65 milliampere minute based on a study with an N of 30. In the same year, Della Cerda published optimal dosage recommendations as 85 milliampere minute based on a study with an N of only 8. Perhaps the largest study was by Harris, also from 1982, with an N of 100 with a claimed current dosage of 100 milliampere minute. What you take away here is that these studies are very low powered and the literature really lacks a very significant basis of high powered evidence on the most appropriate current dosage for iontophoresis to occur. On this slide, a ramp-up protocol is suggested for iontophoresis in a phased-up approach. In phase 1, a 2 milliampere current is mated to a 5-minute timer delivering 10 milliampere minute dose. In phase 2, a 3 milliampere current is delivered over 5 minutes for a further dose of 15 milliampere minute. In phase 3, a 4 milliampere current is delivered over 10 minutes for a total of 40 milliampere minute. Thus, a grand total dose of 65 milliampere minute is delivered over 3 phases. These can be delivered on the same session or split between sessions based on patient tolerance. This brings us to the question of what can be considered an ideal combination of current dosage and drug delivery. In other words, what current dosage would allow the best delivery of the drug? In this regards, a thoughtful consideration would be to answer if equivalent current doses always deliver the same amount of drug. For example, on the left, 3 different strengths of currents delivered over a variable time frame equating to a total of the same dosage theoretically. However, it is not clear as to which method is the best, whether to use a high current with short duration versus a low current with a long duration. In clinical practice, both are used and is open to subjectivity instead of objective data. Another consideration is that of current density that some devices can allow you to selectively manipulate. A higher current density under the delivery electrode will allow a higher ion velocity and more effective drug delivery. However, the higher the current density, the more is the skin irritation at the site. This slide shows you maximum current density at the drug electrode. In treatment methods with the application of iontophoresis, we will discuss the indications and contraindications, the instrumentation used, and the treatment techniques. Iontophoresis is employed for a localized problem of sufficiently superficial nature such that the patient is able to tolerate both the drug as well as the effective current dosage required to drive it in. Contraindications would be similar to contraindications for any electrical stimulator treatment. Broken and/or damaged skin is a major contraindication. This is because charges tend to collect around edges and may result in local discomfort and burns if left unaltered. Decreased sensation in the area would certainly exacerbate the possibility of secondary complications such as burns, as patient is unable to sense the discomfort early. Other contraindications must include allergy to either the specific drug or its components, or allergy to any other drug in the same class. Presence of pacemakers around electrical stimulation units is also a major contraindication, as the electrical field may play havoc with the pacemaker functioning. Implanted metallic devices such as internal bone fixators and/or arthroplasties are general contraindications, though this may be a little controversial. The reasons of accumulation of charge density that can cause burns is the big consideration in such implanted device. As briefly stated earlier, the instrument used for delivery is a standard DC generator used for electrical stimulation. A very basic and rather portable DC generator is shown on this slide in the right top corner. However, there are many hundreds of devices available on the market, some of them uh, more portable and others more stable for clinical use. Additionally, you will find many types of electrodes. We will discuss this in the next few slides. Dedicated iontophoresis generators have several features. Units such as made by MP Dupel come in dual channels with a current range of 0 to 4 milliamperes, and the amplitude can be ramped up or down slowly to allow for accommodation, which is a comfort feature for the patient. The current dosage is also programmable for various applications. You can see more on the MP Dupel unit at the link provided on this slide. Electrodes are needed for machine-patient interface. Electrodes can be cheaply constructed using metal pads wrapped in insulation or using simple gauze, etc. However, it is more common to use standard commercially available electrodes. Standard electrodes are insulated in rubber and connected by insulated wires to the DC generator, though many new designs of electrodes have become available, some of which are single-use or can be reserved for reuse with a single patient. The disposable varieties can be left on, and the patient can go home for over a 24-hour period or similar, and then can be discarded much like Band-Aid. It has, however, to be remembered that these disposable units contain low-powered DC generators. It is thought that at lower amperages of between 2 and 4 milliamperes, the accuracy of delivery may suffer, and of course, these generators may lack other useful features of larger clinic-based electrical stimulation units. The commercial electrodes are available in various sizes. They can be made of fiber or gel and can also have other features as described in manufacturer literature. The primary drawback of commercially available electrodes is perhaps the cost associated with their use. The reusable variety is, of course, the cheapest, but the disposable varieties quickly add up to cost. This slide shows you some popular disposable iontophoresis electrodes with built-in DC delivery generators. On the image on the right, a delivery electrode is prepped by applying the drug, and then the entire unit will be applied to the delivery site on the skin. A battery insulator pullout will start the circuit, and the patient will begin receiving the drug through the patch. The generator lasts varying durations of 8, 12 to 24 hours. After that, the drug has to be reapplied. In clinical practice, the drug has to be obtained by the patient from the pharmacy based on physician prescription. It can be left at the office if so equipped. Some drugs need to be refrigerated. Others can simply be in HIPAA-protected locked units where patient name label is clearly applied. Let's discuss the actual application of the treatment technique. To begin with, skin preparation is paramount. The skin needs to be cleaned very well to reduce its resistance to electric currents. Without proper skin prep, a higher current will be needed to effectively deliver the drug, and this can be of much discomfort to the patient. Next, the drug is applied to the electrode, to the gauze and/or the skin. Commercial electrodes will then need to be affixed. Careful consideration must be given to the position of the delivery electrode and the return electrode. Obviously, the delivery electrode must be affixed over the site requiring treatment. The return electrode must be placed sufficiently close for a local circuit to occur through the skin, but not to cross over into neighboring tissue. On the other hand, electrodes placed too closely together will allow the current to flow directly into the return electrode, thereby not effectively driving the ion through the skin. The electrodes will then need to be correctly connected to the DC generator such that the polarities are maintained based on the drug needs. The current is then ramped up slowly until optimal setting is reached per your analysis. The treatment time is set. Once treatment time has elapsed, the current should be always ramped down instead of suddenly shutting it off, which can be traumatic to the patient. Once fully off, the electrodes are removed, the skin is inspected, and a lotion should be applied locally to soothe the skin. The lotion is not medicated and is not a prescription item, and any commercial skin lotion would suffice. There are more treatment options in iontophoresis, but are beyond the scope of this presentation. For example, consideration for drug concentration. More is not always better. In other instances, there can be use of two simultaneous drugs of opposing polarities or same polarity delivered for different indications. Iontophoresis can also be used for maintaining local pH and with other physical agents, but those are topics for another day. These are some medications delivered via iontophoresis. Appendix 1 in your handout PowerPoint contains detailed discussion of these drugs, their indications, and contraindications, along with other features. These are some more drugs delivered via iontophoresis. Their indications are shown here. In as far back as 1968, Boone suggested that for future development in this clinical area, physical therapists must develop a deeper understanding of the principles of electricity, drug actions and patient reactions, drug stability, and influence of DC current on drug stability. This remains an area of untapped potential in research and future applications. Therefore, further clinical research in iontophoresis needs to develop high-powered RCTs, single subject designs, and case reports to strengthen this area of practice. Let's now review phonophoresis. Phonophoresis in principle is much similar to that of iontophoresis. The major difference is in what is delivery driver for a transdermal delivery. In phonophoresis, an ultrasound transducer is used for driving certain medications through the skin. The parameters of ultrasound are mentioned on this slide. Pause it and review it before you move on. Some possible suggested mechanisms by which phonophoresis achieves its goal is by direct propulsion of the drug through the skin by increasing the skin permeability and/or increasing the cell permeability or response to the drug. It is important to consider the thermal versus non-thermal effects of ultrasound. Thermal effect may cause quick dissipation of the drug from the local area due to increased vascular response. Hence, it is important to choose parameters that are non-thermal so that the drug can remain concentrated at the site of delivery and exert its intended effect. We also have to consider the possibility of the interaction of a drug against the ultrasound. Can ultrasound degrade the drug before delivery? Can it enhance the effect of the drug before delivery? Finally, we also have to consider if the ultrasound itself can be transmitted while using the drug as the interface with the skin. These are some drugs delivered via the skin using phonophoresis. Individual drugs are discussed in more details in Appendix 1 of your handout PowerPoint. In summary, phonophoresis applies two interventions simultaneously, both ultrasound as well as a drug. Physical therapists must consider effect of each intervention separately and possible interaction between the ultrasound and the drug. The therapist must also consider transmission of the coupling medium that contains the drug. Eventually, this approach is similar to iontophoresis in being largely empirical. The usage is based primarily on clinical observations and anecdotal reports in literature that makes application to be very subjective. The drug doses mentioned in the appendix of this presentation is based on the Second textbook, which itself are suggestions only and not based on hard evidence. You have to make a clinical analysis and decision on a case-by-case basis in the clinical setting. In closing, here are your references. You will find reference number 2 and number 3 as part of your reading assignment for this course. As always, follow all copyright laws. Thank you, and for additional questions or comments, please email your professor.